Good morning. My name is Brian McGeeney. I'm delighted to talk to you today about medical marijuana, specifically the clinical applications. Thank you to the organizing committee for inviting me to speak. I have no disclosures relevant to this topic, and we're going to cover these points importantly so we can understand what we mean when we say medical marijuana or hemp, cover the most common purported indications for cannabis, and comment on the extent of the evidence-based medicine for the various purported indications, and finish off with adverse events. The Federal Controlled Substances Schedule Act 1970 placed cannabis firmly in Schedule 1 with no purported medical use and high potential for abuse. And there it has stayed for over 50 years. Notice cocaine is in Schedule 2, in a less highly scheduled than cannabis. And over the last few years in particular, there have been products FDA approved which contain cannabinoids. Most recently, a pure cannabidiol product for refractory seizure disorder in children is a Schedule 5. But for many years, as most of you know, we've had synthetic THC, dronabinol. So currently we have cannabinoids in Schedules 1, 2, 3, and 5.
Marijuana is probably the most dangerous drug in America today.
And what was going on the beaches of Hawaii when that was being heard?
Dreams of my father.
I spent the last 2 years of high school in a daze, locking away the questions that life seemed insistent on posing. I kept playing basketball, attended classes sparingly, drank beer heavily, and tried drugs enthusiastically. I discovered that it didn't make any difference whether you smoked reefer in the white classmate's sparkling new van, or in the dorm room with some brother you'd met down at the gym, or on the beach with a couple of Hawaiian kids who had dropped out of school and now spent most of their time looking for an excuse to brawl.
Thank you, Mr. President. Gateway drug, all right, to the presidency. When we use the term hemp, we're generally referring to the non-psychoactive cannabis plants, which really with the main use of the cannabis plant for a long time. The hemp was a source of high quality fibers for textiles and even paper. So hemp was grown for a long time before the psychoactive component was identified. On the left of the slide, you'll see an article from Popular Mechanics, 1938, the billion-dollar crop. And what was the billion-dollar crop? Hemp. And there on the left, we also have images from the cultivation from the 19th century. Now, medical marijuana clinical studies really took off about 20 years ago. If you see from the slide, the number of published clinical trials using cannabis for various disorders was rather stable up until about the year 2000, when it really took off. And we say medical marijuana. Most of us are aware that California was the first state to enact medical marijuana laws in 1996, and there are now 36 states, along with District of Columbia and most of the inhabited territories. And more than that, approximately 18 states now have recreational marijuana regulations, and the states that are starred on the slide represent those, and even those who don't have recreational, a lot of them have decriminalized, meaning you cannot be arrested. You can be fined, but not arrested for possession of marijuana. Our neighbors in the north, Canada, have fully legalized marijuana in October 2018, after introducing medical marijuana in 2001. Now, some of the criticisms of medical marijuana include the abuse potential, concern over increasing the number of people who are dependent on cannabis. And this may have been just a workaround. Patients really want it recreationally. There's no dose control. It's between the patient and the dispensary. It remains federally illegal. And some would question the amount of scientific evidence supporting the uses. It's wrong to say there is none. There's quite a bit. But still, we are wanting for a lot of more evidence. And the diversion and use by minors is a major concern. Its effect on the developing brain, memory and cognition, and so on. Medical uses of cannabis. Well, the first thing to say is this is not a new therapy. And this headache and head pains image from 1939, and I've cut and pasted 3 recipes there, 3 of my favorite recipes. And we'll see on the top, cannabis, acetylsalicylic acid, aspirin, and bromides. And my favorite one in the middle, morphine, scopolamine, and cannabis. Yummy. That'll get rid of my headache. And so it's really a part of the pharmacopoeia in times gone by. Now, one way to find out why patients are using is asking them. This is a display of 2 surveys of patients who were registered as medical marijuana patients in 2 different states. It's very clear that pain is the predominant symptom people are treating. Severe pain at over 90%. And the next biggest group is the multiple sclerosis group. And they are mostly treating pain and pain from muscular spasm. Next is nausea, and then an array of different symptoms. I'm going to show you this slide again, but this is an attempt to summarize the strength of evidence versus the prevalence currently, the amount of people that are currently using here. And we'll see that on top left, we have a small group which has substantial or conclusive evidence. And that includes certain seizure disorders, symptoms of multiple sclerosis, cancer-related nausea, and appetite stimulation and certain wasting disorders. And there are a lot of purported indications for which there's very little or no evidence, or might be impractical. Glaucoma is down there. There's no question that cannabis reduces aqueous humor production, but that effect stops as soon as the level falls, and you really have to keep a high level all the time, which makes it a bit impractical. And we say medical marijuana, the plant itself has many, many active components and an awful lot of trace components as well. There are many cannabinoids, and only a few have been characterized. On the left is what I think most people think when they think marijuana, they think smoking, but we as healthcare professionals should never advise smoking anything. Smoke is junky on the lungs, contains carcinogens. The inhalational route can be obtained via a vaporizer, which generally heats the product to a vapor and is considerably cleaner than standard smoke. So vaporizers can heat plant material itself or concentrate, such as the liquid. And on the right, we have oral baked goods. I generally suggest that patients purchase or make a tincture. And these are mostly alcohol-based tinctures. And you can drop them on the food of your choice rather than purchasing food themselves. And here we have a topical agent. I took this photo of a patient who was successfully treating her bad neuropathic pain with liberal amounts of this full spectrum concentrate. Full spectrum meaning it's representative of plant, many cannabinoids in it, rather than a single cannabinoid. I also took this photo many years ago of a patient's kind of $10 or $15 vaporizer, which is the most common. Now, vaporizers can also come in family size.
Juliet uses a vaporizer to consume her medical marijuana. It heats up the cannabinoids enough to be able to release the medicine as a vapor, but it doesn't get hot enough to where it's combusting the plant, which is usually the biggest problem that most people have with utilizing cannabis as a medicine, is that they see that combustion is putting tars and carcinogens into your body.
Initially, Juliet was wary of consuming an illegal drug.
I was the Reaganistic child. And it's almost like a nice little meditation ritual.
Well, that's fun for the whole family then, the volcano vaporizer. And here are some menus from dispensaries in case you haven't seen these before. This is for the actual plant material, and they have the 3 or 4 letter cannabinoid mentioned as well, and concentrate. So that's a flower. These are cartridges for the vaporizers. So these are concentrates and edible food products, and then tincture. So the tincture is what you would, a concentrate you would add to food orally. You would not put a tincture in a vaporizer. And as many of you can remember, there was quite a few long injuries from vaping some years ago, likely due to a toxin or contaminant. And it's in particular on those obtaining cartridges from illicit sources. And I don't believe it's much of a concern now when you have confidence in where these were manufactured. So there are now at least 3 cannabinoid products available, as mentioned, dronabinol for many years, for the nausea and vomiting induced by chemotherapy, and also anorexia and weight loss from AIDS, and nabilone with the indication of, again, nausea, vomiting from chemotherapy. And in recent years, as mentioned initially, there is a pure cannabidiol product for refractory seizure disorder in children. We should be aware that there is a under-the-tongue spray, a metered dose of 2.5 milligrams, 2.7 milligrams of THC and 2.5 milligrams of cannabidiol, because this product, a branded product, which is not available in the United States, is available in many countries and is often featured in some of the highest quality evidence-based medicine studies, considering at a metered dose, you know what the patient is getting. And it hasn't quite made it into the American market. The endocannabinoid system is that system of one's endogenous cannabinoids, the receptors they act on, CB1 and CB2, and the enzymes involved in the production and elimination of those endogenous cannabinoids. And these agents have a wide role in regulation of many physiologic processes, and considering how it's hijacked so often by plant cannabinoids, it's amazing that it doesn't do more permanent damage, which it doesn't appear to do. The most well-known endogenous cannabinoids are 2-AG and anandamide, which are both made to order. They're not made and stored in synaptic vesicles. They're made at the time of need. And CB1, receptor 1, is mostly on the nervous system, and CBD2 mostly outside the nervous system, and is highly inducible. The inhalation of cannabinoids result in peak serum concentrations within 10 minutes, unlike oral, where the peak can be as long as 2 to 3 hours, and typically is. And that delay in peak is something that's not appreciated by many folks, younger folks, who end up in the emergency room with cannabis overdose when they've taken orally and didn't realize it takes a long time for peak effect. And there is probably a role for transdermal, at least in treating inflammatory skin disorders. There is some systemic absorption, especially CBD, cannabidiol. And the cannabinoids tend to have a long half-life and accumulate in adipose tissue. And so in the heavier users, it can take even weeks to get a clean urine. And I'm going to say a little bit about drug interactions later on. I may have mentioned the entourage effect, the summation effect of the many biologically active cannabinoids and other agents in the plant is thought to be responsible for a better clinical outcome for many indications rather than a single or cannabinoid. That's the argument in favor of using plant and plant-based rather than just single synthetic, for instance, cannabinoids. The cannabis plants also contain terpenes, as do many other plants. And terpenes have been hypothesized to be important in the clinical response, although we really don't have great evidence for that. There are many hypotheses about their usefulness. The one thing we can be absolutely sure of with terpenes is that it's responsible for the fragrance of cannabis. And you might be more familiar with the terpene Taxol, the anti-neoplastic agent. And there are street synthetic cannabinoids, which are full agonists at the cannabis receptors, makes them dangerous, very potent, and one can easily get toxic, neurotoxic, including seizures and vascular effects, including stroke, and to be avoided at all costs. The one factor, unfortunately, that might drive some patients to the use of these agents is they will not turn a standard urine screen for THC positive. They will not. Some of the medical complications for K2 or spice. Cannabidiol is the second most well-characterized cannabinoid. Although known as non-psychoactive, it's probably more appropriate to use the term non-intoxicating. And that's surely true. It really isn't intoxicating, but it does have plenty of biologic effects and is thought to possess anticonvulsant, analgesic, and anxiolytic, antiemetic, immune modulating, anti-inflammatory, and neuroprotective effects, with some evidence for each of those. The bioavailability is low and the half-life is long, and you can increase the absorption with a fatty meal. There are many channels where you can purchase CBD products now, and the legal aspects are a whole lecture in itself. They are strictly still Schedule 1 illegal. It turns out that cannabidiol's actions, or its important actions, are really not at the cannabis receptors. There are now over 65 discrete molecular targets that have been identified, and a lot of those are dead ends, but a lot of those are not. It has widespread effects on enzymes and receptors, as diverse as the serotonin receptor agonist, to 1A agonist, to a TRPV1 agonist, TRPV2 agonist, and so on, as you can see on the left there. So it turns out that the actions are in fact very complex. In some ways, it makes it easier to hypothesize positive roles, theories, and how it might be beneficial, but one would rely even more so on clinical studies in this setting. And the accuracy does vary on source. CBD is quite a lot of variation in the amount in the products purchased. The products purchased through a dispensary have a more reliable amount. So when somebody asks, does cannabis work for disorder X, what you're really asking is, what preparations and administration routes may have potential in the treatment of X, and what preparations and routes don't have potential? And the way one should answer that is, what's the current clinical evidence and where does it fall in the evidence hierarchy? And secondly, what's the scientific rationale for a possible benefit in connection with any particular disorder? When bear in mind that scientific rationales are cheap, it's very easy to do, and one should hold a high bar for such rationales. Here is the range of disorders which are purported to be helpful, quite a lot. I want to focus for the next few minutes on pain and chronic pain. With the 2015 meta-analysis in JAMA on cannabis, that really got a lot of attention, and overall kind of positive for chronic pain. There was a moderate quality evidence to support the use of cannabinoids for the treatment of chronic pain. And I won't go into it in detail, but they identified about 28 studies for that conclusion. And there were a number of other meta-analyses in cannabis for chronic pain that followed in quick succession. That a publication in Pain Physician, which was media positive and negative, really wasn't that supportive. Annals of Internal Medicine was a positive. Limited evidence suggests that cannabis may alleviate neuropathic pain in some patients, but insufficient evidence exists for other types of chronic pain. And then in 2017, the National Academy of Sciences, Engineering and Medicine published the report, The Health Effects of Cannabis. And they identified 30 randomized controlled trials for chronic pain in particular, and noted there was conclusive or substantial evidence that cannabis or cannabinoids are effective for the treatment of chronic pain in adults. And that 455-page report, and there it is. Now you can get it online. It very detailed in what they've identified as which there's considerable evidence, and also detailed what there is only limited evidence for. And I would draw your attention to one, there's substantial evidence of an association between cannabis use and schizophrenia and other psychoses, which may raise the question of, does cannabis cause a psychiatric disease, or is it really triggering it in susceptible individuals? And that was furthered by a publication in the Lancet Psychiatry in 2019, which attempted to purport a causative link. And however, there were a few letters to the editor in connection with this issue of whether cannabis can cause psychosis, apart from the acute intoxicating effects, and does appear more likely that it's not so much causation, it may be irritation of a susceptibility. So back to the meta-analysis for pain, Cochrane Review 2018 was somewhat negative, 16 randomized controlled trials in neuropathic pain, lack of good quality evidence, rather typical of a Cochrane Review, lack of evidence. And then also another meta-analysis in pain 2018, also somewhat negative. It was a mixture of our randomized controlled trials and observational studies. And 2019, Cochrane Review again, this time more positive. Meta-regression, meta-analysis on chronic pain. Outcomes suggest cannabis may serve as effective replacement or adjuvant option for pain, which is great. And 2020, BMJ, meta-analysis cancer pain, low risk of bias studies with advanced cancer. Addition of cannabinoids to opioids did not reduce pain. That was a negative. And finally, 2021, another publication, the BMJ, chronic cancer pain and non-cancer pain, which was lukewarm, moderate to high evidence, non-inhaled cannabinoids reduce or results in a small to very small improvement in pain relief, physical functioning, and sleep quality among patients with chronic pain. So that was a mild positive. So like many opinions in life, the way your attitude to this is dependent on many things. And so often the case, you can backpedal whatever side you take on this, you can backpedal and reference the relevant meta-analysis that back up your own opinion, be it positive or negative. So even though the meta-analyses had a lot of crossover in looking at the same data, the summary words can differ. The European Pain Federation has a position statement on the use of cannabis for chronic pain, and they do see a role when other things have failed for neuropathic pain, maybe third line. And they have some specific warnings and concerns in connection with anesthesia. Patients, the cumulative sedative effect, or patient may need more propofol. These are just observations. Canadian primary care guidelines looked carefully and said, well, one could consider cannabinoids for refractory neuropathic pain, refractory pain in palliative care, chemotherapy-induced nausea and vomiting, spasticity in multiple sclerosis, and spasticity with spinal cord injury, and for those who have failed more standard therapies. That's a positive. American Academy of Neurology, nearly 10 years ago, now has suggested there's a level A evidence for the use of oral cannabinoids in the treatment of the symptoms of spasticity and pain. The objective spasticity is not as easy to demonstrate, unfortunately, and that by its nature, it's not that easy. And here's a table on neurologic and psychiatric conditions and treatment of. It's a few years old, but still very few phase 3 studies, and a lot of indications of just observational studies or very limited other interventional studies and favor. Cannabis for psychiatric disorders. The data currently do not support the use of cannabis for any mental health diagnosis, despite there being a lot of purported treatment for anxiety or mood. Most promising evidence is for CBD as an adjuvant treatment in schizophrenia, and a positive study in social anxiety, and also weak data supportive in ADHD. And it's likely cannabis has a role in helping insomnia, especially short term. And that's often noticed very easily by patients, but is not well reflected in the literature as yet. What do oncologists think of medical marijuana for pain management? A study from 6 years ago now asked about the effectiveness versus standard pain treatments, the rule of thirds. 1/3 thought it was equal or more effective, 1/3 less effective, 1/3 didn't know. But as regards an adjunctive to standard pain treatment, to some or a great extent for 2/3 of practitioners, and at least 80% discussed medical marijuana with their patients. Cannabinoids in epilepsy, I mentioned there's a product, Cannabidiol. It must be pointed out that THC and the synthetic THCs can provoke seizures. They have the totally opposite reaction. And it's patient observations on the anti-seizure effect of cannabidiol that prompted randomized controlled trials and enabled a branded product to become available. It also enabled further study on drug interactions, and we know that the drug interaction of note with these patients is seizure disorder patients, clobazam, which is a benzodiazepine-like agent, active metabolites, considerably increased in those taking cannabidiol. Cannabinoid treatment for cancer. Well, apart from cancer pain, in recent years, multiple studies looking at cannabinoids in targeting and killing cancer cells, and there are cancer-related pathways that are modulated by cannabinoid agonists and can lead to block of cell cycle, inhibition of cell proliferation, and even cell death. Cannabinoids induce synthesis of ceramide, a pro-apoptotic agent, and also cannabinoids manifest anti-angiogenesis effects, mostly by inhibition of VEGF. On the left, I pulled up a very recent paper, small number of people, 21 patients with glioblastoma undergoing the standard treatment, temozolomide, and additionally 12 received nabiximols, which is the under the tongue metered dose spray, of cannabinoid and 9 had placebo. And the 1-year survival was 83% in the cannabinoid group and 44% in the placebo group. Sounds great, but very small numbers. All that means is it needs to be repeated. These are hypothesis generating. They're so small, but it's great to see. So I told you I'd show you this slide again as a reminder. The strength of evidence and the number of patients I feel are using these agents. Here we have the most evidence, and some of the least evidence can even be the most common for mood, anxiety. I do feel that there'll be more evidence for sleep in the future. And glaucoma, it certainly does. Cannabinoids certainly do reduce aqueous humor production, but as soon as the serum cannabinoid level falls, the effect falls. So you really have to have the level all the time, which is a bit impractical. Drug interactions, what you need to know. So strong or moderate inhibition of CYP3A4 or 2C19 increases THC level. So that includes the protease inhibitors, the certain antifungals, even fluoxetine, verapamil, even PPIs, and can increase THC level. And you can reduce THC level with induction of those same enzyme groups, such as rifampicin. High protein binding. So THC can displace the medication, so you can get a greater effect of warning with Coumadin. The THC is a substrate and inhibitor of drug metabolizing enzymes. So in summary, one would be particularly cautious about medications that are metabolized by 3A4, 2D6, 2C9, 2C19, are highly protein bound and narrow therapeutic window. And it's long been said that cannabis can be opioid sparing for people in pain. And although it's often said, there really isn't good quality evidence to that effect. There is some evidence that is hypothesis generating. And it still lies in that hypothesis generating group. It's intriguing. Adverse events, well, but there are many systems which are reported to have adverse events from cannabis. To talk about the first one should talk about the lungs. And smoke is junky, smoke is carcinogenic, any smoke. And that includes cannabis, so one should never smoke. All smoke can induce chronic bronchitis. What is clear, the difference between cigarettes and cannabis is the cancer link. So large epidemiologic studies with small or medium usage of cannabis, even smoking cannabis, there is no cancer link. And it is debatable and hazy whether long-term high-dose use is linked to cancer. I expect it would be, because that's a lot of smoke exposure, and smoke contains lots of carcinogens. It just makes sense. But there's no question that it is safer than cigarette smoke in that capacity. Cardiovascular effects, cannabinoids increase sympathetic tone, increase heart rate, increase cardiac contractility. So one would expect, theoretically, more cardiac events. And that does appear to be the case with what evidence we have, observational studies. There does appear to be a greater association with cardiac events proximate to use of cannabinoids. This also raises a very difficult management issue in those who likely have heart disease or do have heart disease with respect to medical marijuana, and how aggressive one is going to be about trying to stop that. It's not risk-free, but then one could say neither are decongestants. There is a cannabis withdrawal. For a long time it was thought there wasn't. It's just mild for the most part. And the heavy user, certainly on cessation, can develop anxiety, irritability, restlessness. But it wouldn't be as bad as caffeine withdrawal, for instance. But it certainly is a withdrawal. Dr. Kevin Hill wrote an excellent piece in JAMA in 2015 with a critical eye to medical marijuana. And among other things, he reminded us of the potentially addictive nature, causing significant problems with work, school, and relationships in about 9% of adults and 17% of adolescent users. And the reason I show this is an article on medical marijuana, but the references he uses for those prevalences are street drugs, street marijuana. And I would make a suggestion that your risk in using medical marijuana is likely, that population is less of an at risk. Anyone can be at risk, but overall the risk would be less than the population using street drugs, street cannabis. Cannabis hyperemesis syndrome is an interesting syndrome of refractory nausea and vomiting associated with frequent daily cannabis use. The only treatment that's any good is cessation. The standard antiemetics don't do much good, and the parenteral haloperidol or olanzapine can be a little better. And these patients, often young, repeatedly present to emergency rooms. And one of the giveaways is the compulsive hot showers, which induce a remission in symptoms for a short time. So in summary, I've presented to you at least 3 agents which have FDA approval cannabinoids for various indications: nausea and vomiting, chemotherapy, treatment of seizure disorders. You need to know that there's a metered dose spray, under the tongue spray, which is often used in the best evidence, although it's not available in the United States. And meta-analyses of chronic pain generally are supportive. Most evidence for neuropathic pain, and to a lesser extent in cancer pain and other pain. We do lack the largest trials that many other products have. And there are many proposed uses with limited or no evidence. There's been particularly interest in CBD, being that is non-intoxicating. And it's probably prudent to avoid or be very cautious in the use of cannabis in those who have significant psychiatric, hepatic, cardiac, or renal disease. And with that, I will say thank you very much.